Welcome to Day 2 of the 2013 International Disability Rights Affirmation Conference, IDRAC. The theme of this year's conference is Let Me In. My name is Pecos Kidd, and I'm Vice President of Virtualability, Inc., the host of this conference. Virtualability is a real-life, nonprofit corporation and an SL community. For more information about us, please click the poster on stage to receive a note card or check out our website at www.virtualability.org. To find out more about this conference or to leave a comment about the presentations, please look at the information at our blog, blog.virtualability.org. If anyone needs assistance during the conference, please IM one of the VAI greeters who are standing in the aisles toward the back of the auditorium. We have a very busy sim today, so if you could remove any scripted items, such as face lights or HUDs, we would appreciate it. Metaverse TV is recording this conference and streaming it live on the internet at livestream.com/metaverse business. We thank them for that effort. For maximum accessibility, Virtualability offers our presentations simultaneously in both text and voice. This helps people who are hearing impaired or deaf, who are multitasking while their avatar is in world, or whose first language is not English to participate fully and in real time. For the question and answer portion of the presentation, our transcriptionist will be doing meaning for meaning transcription, not word for word. Our keynote speaker today is Dr. John Stone. Dr. Stone is the director of the Center for International Rehabilitation Research, Information, and Exchange, CIRRIE, at the State University of New York at Buffalo. The mission of CIRRIE is to facilitate sharing of information among rehabilitation researchers around the world. Today, Dr. Stone will be talking to us about the World Report on Disability. Dr. Stone, on behalf of Virtualability, welcome, and please begin.
Well, thank you for the kind introduction. This is my first time presenting in the Second Life environment, so I hope you won't mind if I am a bit clumsy at times. Discovering virtual ability was a great revelation for me, and I am most grateful to it for inviting me to participate in this conference. I direct the Center for International Rehabilitation Research, Information, and Exchange, CIRRIE, which has a number of resources on our website that might be of interest to many in the audience. This includes a database of research conducted in other countries, an encyclopedia of rehabilitation, and many resources on culture and disability. In 2011, the World Health Organization, WHO, and the World Bank released the first World Report on Disability. Today's presentation will include some explanation about the World Report, about what the World Report is, why it was developed, how it was developed, and most importantly, what is in it. What does it say? In September of 2011, our CIRRIE project, with support from the National Institute on Disability and Rehabilitation Research, conducted the two-day U.S. launch and symposium on the report. This was done in cooperation with WHO, the World Bank, the Pan American Health Organization, the Interagency Committee on Disability Research, and the U.S. International Council on Disability. The purpose was to discuss the implications of the report for U.S. disability policy, both domestically and internationally. The presentation slides from that event are on the CIRRIE website, as well as a video of the entire two-day event. Today's presentation will try to capture in 60 minutes some of the highlights of the report. The World Report on Disability can be put in the context of an international trilogy on disability. In 2001, WHO published the International Classification of Functioning, Disability, and Health, the ICF, which we can think of as an analytic framework on disability. In 2006, the UN launched the Convention on the Rights of People with Disabilities, which is a legal document that embodies values related to disability. Shortly after, the UN commissioned WHO to develop a World Report on Disability. The World Report is related to the other two documents. It uses the ICF as a reference, as a frame of reference, and it supports the convention by presenting the state of affairs on disability globally and points to ways forward to improve the situation. The aim of the report is to provide governments and civil society with a comprehensive description and analysis of the importance of disability and the responses provided. Also to make recommendations for concrete action that will generate real change based on the best available scientific information. The report took 4 or 5 years to prepare. It involved a large number of contributors from over 70 countries. It's quite possible that some of those contributors may be in the audience today. WHO worked closely with disability organizations and included many persons with disabilities on its editorial board and as contributors. There were regional consultations on a preliminary draft, which resulted in major revisions. One of the major findings was the first revision of global estimates of disability prevalence since the 1970s. In the 1970s, WHO estimated that there were 10% of the world's population were of people with disabilities. In the absence of national data, many countries used 10% in their planning, which greatly underestimated the need for services. The current estimate in the report is 15.6%. The numbers are increasing due to the population aging and an increase in chronic conditions. And disability affects disproportionately vulnerable groups such as the poor, women, and other groups. The report identifies many barriers affecting people with disabilities, including inadequate policies, negative attitudes, lack of services, and problems with service delivery, as well as inadequate financing and lack of access. Also, lack of consultation with and involvement of people with disabilities is another barrier to progress. And finally, the report noted that there is a lack of data and evidence related to disability and ways to service people with disabilities. Now, the report is organized into 9 chapters, and in the remainder of this presentation, I will try to summarize each of the chapters. Each of the chapters could have a separate seminar devoted to it, so I will just be able to touch upon a few points from each. Hopefully, it will whet your appetite, or whet the appetite for those who have not yet read the report. The first chapter analyzes the nature of disability. Now, this should be familiar territory to those of you who are participating in this conference. But the primary target audience for the report was policymakers, not all of whom may understand what we mean by disability. And WHO thought that it was important to get this right before getting into more specific chapters. So a contrast is made between the medical model and the social model of disability. The medical model says that the cause of disability is a condition of the body as a consequence of a disease, accident, or birth. The social model says that disability is caused by society because of attitudes and the environment. The ICF combines both aspects and views disability as arising from an interaction between characteristics of the person and characteristics of the environment. We can see this in a simple example. This person can't go to school. Why not? Well, because he can't get up the stairs. But if there were no stairs, nothing would prevent him from being a student. But on the other hand, if he could walk, if he did not have a spinal cord injury, the stairs would not be a barrier. So we can see that it's really a combination of these two factors that is creating the disability. This way of understanding disability has some positive consequences. First, it recognizes that disability is not an attribute of the person. Second, it means that participation can be increased by focusing on barriers. Inaccessible environments create disability. And I guess we can see that in this virtual Second Life environment that is equally accessible to all. And some of us newcomers who are less able in this environment, such as myself, would not be considered disabled in the real world. Of course, it is important to recognize that environments include not just the physical environment, but attitudes and policies as well. Chapter 2 contains information on disability prevalence and trends, as well as the socioeconomic situation of persons with disabilities and the cost of disability. Estimating prevalence of disability has been difficult because of different definitions of disability, and different instruments resulted in different data in different countries and even within the same country. Some estimates used physical conditions, others used functional difficulties or participation. Some used self-report, others used an assessment by a professional. Some estimates were based on data from a general census, others from specific disability surveys. As a result, there was variation among countries, ranging from 1% to 30%, which of course was not accurate. WHO tried to standardize surveys. It developed a methodology based on the ICF and piloted it in 2002 to 2004. It was the largest multinational disability survey ever. Not all countries were included because it focused on countries that did not have data, for example, developing countries such as some of those in Africa, but it also included some rich and middle-income countries in order to get global estimates. The U.S. was not included. The result was the first revision of estimates in 40 years. 15.6% of the world's population are people with disabilities, according to this estimate. And that translates into 1 billion persons worldwide. 2.2% of the world's population are persons with very severe disability. The rates are higher in poor countries, and there are higher rates among vulnerable groups, such as the poor, women, and elders. The aging of the population increases the prevalence of disability. Disability has costs, although they are difficult to measure. There are costs to the individual and costs to society. The costs to society include lost productivity, taxes lost because of unemployment, higher costs of health care, adaptations to public facilities, and benefit payments. Some of the costs to the individual include assistive devices, more expensive transportation, personal assistance services, home modifications, among others. Some of the recommendations in the report related to disability statistics include adopting the ICF for surveys as a framework for surveys, improving national disability statistics, for example, using difficulties with functioning approach instead of an impairments approach, improving the comparability of data among countries, developing appropriate instruments. The next chapter deals with health. Chapter 3 is on the health of persons with disabilities, and it discusses the health status of persons with disabilities, how health services can diminish disparities, barriers to using health care, and how to overcome the barriers. Disability often brings with it secondary conditions that compromise health. For example, depression, pain, pressure ulcers, physical activity, which we know is important for health, is sometimes difficult for persons with disabilities. And sometimes some types of disabilities have a greater impact on health than others. Some negative health consequences sometimes associated with disability are premature aging, obesity, unhealthy behaviors, for example, substance abuse, greater risk of violence. For example, blind persons may not be able to identify their attackers, and deaf persons can't call out for help. Greater risk of accidents, for example, falls and burns, and a higher risk of premature death. There are unmet health needs at 3 levels: health promotion, prevention, and treatment. And here we are not talking about prevention or treatment of disabilities, but rather secondary conditions or comorbidities. Some examples include, in the areas of physical fitness, there is a need for adapted gyms and gym equipment. For cancer prevention, mammograms usually require the woman to stand, which might be difficult for some persons with physical disabilities. In the area of sexual and reproductive health, many healthcare professionals assume that people with disabilities don't engage in sex or have children. Mental health services are not available for many who need them. Some areas that need to be addressed are the accessibility of health services, which includes eliminating discrimination, as well as ensuring that the built environment of health facilities are accessible. Ensuring that health services are affordable, given that persons with disabilities often have higher health costs. Making sure that health services are located as close as possible for persons with disabilities, and ensuring that the quality of health services is equal to that of persons without disabilities. Some of the barriers that persons with disabilities experience in accessing health facilities include the parking areas, narrow doorways, inadequate signage, external and internal stairs, inadequate bathrooms, and inappropriate equipment. The example we cited before was the mammogram in a standing position. As an example, the report cites a Brazilian study that found that 60% of primary care units in that country were not accessible. Other difficulties that people with disabilities experience in the healthcare system are in the areas of transportation and communication. For example, the majority of people with disabilities in the U.S. say that transportation is a great health problem. Another example is professionals who turn their heads when speaking with deaf persons, making it impossible for them to read lips. Counseling about HIV/AIDS is seldom offered in sign language for deaf persons. Written materials on health are often not available in Braille. Time for appointments. Many persons with disabilities have health conditions that are multiple and complex, and that often requires more lengthy appointments. But professionals in many countries are not reimbursed for the extra time, which creates disincentives for treating people with disabilities. One source of the problem that people with disabilities experience in the health system is due to the personnel who work in the system. Professionals sometimes have preconceived beliefs about people with disabilities, for example, that they do not engage in particular types of activities. Professionals often lack knowledge and skills related to primary and secondary conditions common among people with disabilities. The reason is often that the curricula of the programs that train health professionals are deficient on subjects related to disability. Chapter 4 is on rehabilitation. Now, as you can imagine, a report that covers the whole world with countries at different stages of development and different levels of resources was a challenge. And this is true for the chapter on rehabilitation. The chapter does attempt to define rehabilitation globally, identify challenges, especially in low-income countries, and offer some recommendations. For the purposes of this report, rehabilitation includes rehabilitation medicine, the therapies, for example, occupational therapy, physical therapy, speech therapy, and assistive technology. The report notes the lack of data globally on needs, but suggests some proxy measures for such estimates, such as data on the prevalence of disabling conditions and the demographics of aging. Waiting times for services can also be an indirect indicator of need. In a global survey on vision services in urban areas, the waiting time for services was less than 1 month in the rural area. The waiting time for services was less than 1 month in urban areas, while in rural areas it was 6 to 12 months. The report discusses challenges in a number of areas, such as human resources planning and organization of services, assistive technology, and research. In the area of human resources, the report notes some vast disparities among countries and regions in the availability of rehabilitation professionals. The training and retention of these professionals presents challenges in many countries. The report identifies 3 levels of personnel: university trained, persons with training at the secondary level, and those with very little formal training, such as people who live in the community and work in community-based rehabilitation programs. Now, this is a somewhat different vision of human resources than we have in the United States, where rehabilitation professionals are usually university trained. But in many countries, those personnel do not exist in sufficient numbers, nor are there university programs that could meet the need for such human resources. Consequently, at least in the short term, the report suggests increasing the supply at the mid-level, either through generic training across specialities or profession-specific assistance. One advantage of this approach is that mid-level workers would be less able to migrate to developed countries. The advantage of community-based workers who provide basic services and referral is that they are close to the people who need the services, thus meeting basic needs with minimal training costs. Where national training centers are not yet available, regional training centers have partially filled the need. And rehabilitation can be better integrated into the healthcare system as a whole. In the absence of rehabilitation specialists, more training in rehabilitation should be given to primary care workers. Policies to retain rehabilitation professionals need to be considered, since many rehabilitation professionals migrate to other countries or leave the profession. At the system level, there is often a lack of clear and consistent policy for rehabilitation, with programs and financing spread across several ministries, or in the case of the U.S., several departments. Rehabilitation is often underfunded, even in comparison with general health care costs. Countries with limited resources often need to prioritize, allocating more resources to life-threatening conditions rather than disabling ones. Rehabilitation services tend to be centralized and often are unavailable outside urban centers. The report recommends revising policies, laws, and systems. It recommends national rehabilitation plans or revising those that exist. It recommends increasing services and decentralizing them. The benefits of assistive technology are noted, but there are problems in the provision of devices. One of them is the cost to the consumer or to the provider. Matching the device to the consumer and the environment is essential, as are training and follow-up. In many locations, it is difficult to find assistance with maintenance and repair of assistive devices. The report recommends cost reduction through economies of scale in production and purchasing and reducing import taxes. More attention to the selection of devices and training of the user of devices is needed. There also needs to be better follow-up to see that the needs of the user have not changed. And the provision of maintenance locally is very important. The report cites the need for research to enable evidence-based practice in rehabilitation, but notes some areas of concern. Some aspects of rehabilitation have received less attention than others, and among them are research on the links between needs, receipt of services, outcomes, and cost. Research on access barriers and facilitators, models of service provision, and approach to human resource development. Research on the cost-effectiveness and sustainability of programs, including community-based rehabilitation. Difficulties in rehabilitation research are noted. Some of the difficulties that make certain types of rehabilitation research more difficult than research in some other fields are the lack of a common taxonomy of rehabilitation interventions, the fact that interventions are usually simultaneous, making it difficult to identify the effectiveness of each of them. Outcome measures for activity and participation are lacking. Rehabilitation, the small sample sizes typically characterize rehabilitation research, and the denial of services to have a control group for control trials are not feasible in rehabilitation. Some general recommendations of the report related to rehabilitation research are: increase the relevance of research by involving consumers, that is, people with disabilities, in its planning, including the identification of topics. Use of the ICF where appropriate to communicate across countries and across professions. Consider a range of methodologies, or a wider range of methodologies, and attention to dissemination and knowledge translation to make sure that research results are actually implemented, and more international collaboration in research. Now, Chapter 5 is on assistance and support, and this refers to services other than health and rehabilitation. For example, sign interpreters, personal assistants for daily activities, seeing eye dogs, help with finances for persons with intellectual disabilities, respite care, peer counseling and support. These are some examples of other types of assistance and support that are useful for people with disabilities. However, a major focus of this chapter is on caregiving. Caregiving is usually provided by families, but nowadays several factors are making caregiving more difficult for families. So even in countries with a strong tradition of family support, things are changing. For example, families are becoming smaller, reducing the number of available caregivers. Families are becoming more geographically dispersed as members find employment in other cities, other states, or even other countries. People are living longer, increasing the number of years that caregiving is needed. Some of the impacts of caregiving on the family are stress due to less time, more work, and less sleep, less opportunity for employment, more demands on children, and difficulties increase as the caregivers themselves become older. The other alternative is formal caregivers. But who will pay them? And who are these paid caregivers? Other problems with formal caregivers are their lack of them in sufficient numbers, their compensation, inadequate training, and high turnover. In some countries, caregivers are recent immigrants with a poor command of the local language, making communication difficult. Caregiver services often lack proper coordination. In some cases, the person can become overly dependent on the caregiver. And abuse by caregivers is not unknown. The report suggests several strategies in this area. A system of support services needs to be created when they do not exist. The system needs to be financed with co-pays by the users. Often a public-private voluntary partnership is effective, with non-governmental organizations providing the services with financing by the government. Services should be based on an assessment of the needs of each individual. Personnel should be subject to regulations and standards. Persons with disabilities should maintain control over the services they receive to the extent that they are capable of making these decisions. Where caregiving is done by families, the report recommends these strategies to assist them. Respite services should be provided to prevent burnout. Some form of financial support should be provided to recognize the contribution of caregivers and the opportunity costs they incur, for example, foregone unemployment. Psychological support to overcome stress and isolation. Paid medical leave is a strategy used in some countries. Caregivers also need access to information and training that would make their care more effective and less stressful. Chapter 6 is on enabling environments. In this chapter, environments refers to buildings, homes, streets, transport, information, and communication. There is an interaction between environmental access and other chapters. For example, transportation is necessary for work, education, and health services. And communication, people need to be able to use communication media to do just about anything. Here are some examples. Persons with hearing impairments require equipment to amplify sound, good room acoustics, sign language interpreters, and bilingual education in sign. Persons with visual impairments need material and audio in large print, screen readers for computers, and magnifiers. Persons with intellectual impairments may need information in clear and simple language. Persons with speech impairments require alternative and augmentative communication systems. A UN survey found that even in countries that have official policies about accessibility, 54% of them are without standards for streets, 43% of them don't have standards for public buildings, 44% are without standards for schools and healthcare facilities, 58% do not include resources for accessibility in their budgets. So clearly, there is a gap between policy and implementation. Why is that? The report cites the lack of financial resources, the lack of planning and design capacity, the lack of enforcement mechanisms, the lack of participation by people with disabilities, and the lack of training on accessibility in the curricula of architecture, planning, and engineering programs. Are accessible buildings more expensive? In new buildings, accessibility increases the cost by only 1%. Adapting existing buildings is much more expensive. The report suggests that in poor countries, implementation of accessibility regulations be done in stages, what the convention calls progressive implementation. For example, making sure that at least the ground floor of buildings and public bathrooms are accessible in the short term, and then progressing to other goals. It is important to note that most standards concentrate on accessibility for people with mobility impairments. But we also need standards for accessibility for people with sensory impairments and intellectual impairments. For transportation, the report discusses two areas: improving access to public transportation, for example, buses and metros, including the platforms, the pedestrian area around the station. But it also cites the need for special transportation services for people with disabilities, for example, shared vans and accessible taxis. In the area of information and communication, people with disabilities should have the same choice in telecommunications as other people in access, quality, and price. They need such things as captioning for TV and the internet, alternative computer controls for people with impaired motor abilities. Now, standards in this area lag behind standards in transportation and the physical environment. Also, in communications technology, that area changes more rapidly than it does in other areas, and it's more difficult to keep pace. There are incentives to industry for paying attention to accessibility. Accessible internet sites can be easier to use for everyone. An example, what we now call universal design. Products and environments that are usable by people with all abilities. Accessibility offers market benefits, especially with an aging population. A company that designs for all can sell to all. Looking towards the future, we can have enabling or disabling environments. We need to create a culture of access in which we automatically plan for access rather than adapting things after the fact. We need better information about environments and their accessibility, and we need effective enforcement of laws and regulations. Chapter 7 is on education. The report notes that exclusion of persons with disabilities from education and employment has a high social cost, because poverty is associated with disability, but education weakens this association. But children with disabilities are less likely to start school and have lower rates of staying in school. The report discusses 3 approaches to providing education to persons with disabilities. There are special schools, which only children with disabilities attend. There are integrated schools, which are regular schools with special classes for children with disabilities. And there are inclusive schools, where children with and without disabilities study in the same classroom. The research on the comparative effectiveness of these 3 approaches is inconclusive. However, the report recommends inclusive schools in most cases, citing several advantages. The first advantage is educational. When teaching is based on individual differences, there are benefits for all students. A social benefit is that in inclusive schools, students learn about disabilities and change their attitudes about children, their classmates, who may be, quotes unquote, different. Finally, there is an economic advantage to inclusive schools. Having different types of schools for different groups of children is more costly. Barriers to inclusive education at the system level include policy, plans, and financial considerations. The average cost of education for a child with disabilities is twice the cost for others. At the school level, barriers include inadequate teacher training and support, physical barriers including transport and buildings, attitudes including the low expectations of students with low expectations for students with disabilities. Another barrier is violence and abuse of children with disabilities, which prevent many of them from completing their education. Some of the strategies for educating children with disabilities include individual education plans that include educational objectives for the individual, teaching methods appropriate to meet those objectives, and adaptations and support required for success. Students with disabilities should participate in activities, not just be physically present for them. There should be support for the school to enable it to educate students with disabilities, and this support includes access to specialists in special education, as well as teaching assistants to enable teachers to do multitasking required in an inclusive classroom. Finally, having teachers with disabilities provides a role model for students with disabilities, an example for all students of the capabilities of people with disabilities. Oops. Chapter 8 is on work and employment. The report notes that the majority of people with disabilities are unemployed. Unemployment rates vary with type of disability. Exclusion from the job market is a reason for poverty among persons with disabilities. Physical barriers and the lack of transportation make it difficult to seek employment and remain unemployed. Negative attitudes, misconceptions about productivity, and discrimination limit employment opportunities for people with disabilities. 52% of males with disability are employed, while only 19% of females are employed. The rate of unemployment is higher for persons with mental illness or intellectual disabilities. Some of the factors of the unemployment of people with disabilities noted in the report are disincentives to work, for example, the loss of benefits for people with disabilities, which are often greater than the salary that they might receive by being employed. Many people with disabilities work in the non-formal sector. That is, they are self-employed. Many persons with disabilities work part-time. In the United States, it's 44% for people with disability versus 22% for people without disabilities. And people with disabilities generally receive lower salaries. Barriers to work and employment include lack of education and training, lack of access to small business loans, misconceptions about the productivity of people with disabilities. Some strategies for increasing the employment of people with disabilities include anti-discrimination laws and rules. For example, in Brazil, they have a clause in the Constitution itself. Reasonable accommodations in the workplace that include assistive technology and flexible scheduling. Some countries have quotas for companies. That is, a certain percentage of their employees must be people with disabilities, and there are penalties or fines for not meeting these quotas. And the fines then fund programs for training and job placement for people with disabilities. Other countries have incentives for companies that employ people with disabilities. And these incentives may be tax deductions or government funding for accommodations. So penalties punish companies for not employing people with disabilities, while incentives reward them for doing so. Some strategies include supported employment, especially for persons with mental health conditions or intellectual disabilities. In this approach, people with disabilities work together with people without disabilities. Protected employment, in which people with disabilities work separately. In some countries, non-governmental organizations act as employment agencies. For example, the Independent Living Center in Rio de Janeiro does that, as well as the ONCE Foundation in Spain. Training and development is important, and this includes vocational training, especially community-based vocational training in which local artisans provide training and there is help with microfinancing. Peer training is particularly effective. Mentoring and internships in companies are helpful. Attention should be paid not just to initial employment, just getting a job, but also to promotion and career development. Labor unions can be a facilitator or a barrier, so the disability community should learn to work with them. So the report is a vast repository of information on disability worldwide, and I've attempted to provide a brief summary in this presentation. Many of you may wish to read the full document, and the report is available on the WHO website at this address. Or you can simply Google the World Report on Disability and you will immediately find links to it. I might add that there are some short videos on that site that show how some people with disabilities in different countries are striving to obtain their full potential, and that illustrates some of the points that are made in the report. And the report is available in many different languages. Well, I'd like to thank you for this opportunity to interact with you. And I understand that we will now have some time for questions and comments. Thank you.
This is Jeff. Thank you, John. That was really. I'm also going to put out a little giver box down by the base of the podium, and I'll give you some more additional information about CIRRIE. So if you want to find this, then you'll have more information, folks. It's as much handouts in the folder. If I can get second line to this. See. There we go. There's,
Thank you very much,
notes.
Dr. Stone. Very nice presentation. Thank you. Are there questions from the audience?
Let's focus on disabilities. How important is it that the U.S. has not ratified the UN Convention on the Rights of Persons with Disabilities? Dr. Stone, if you can turn on your voice when you speak, I will take.
I'm not hearing the audio, but I did see a couple of questions pop up on the screen there in text, and so I'll be able to address them in that fashion. I think the first question was related to the top-down and bottom-up approach, and the questioner asked if the report contains any information on bottom-up strategies for gathering information and input. And yes, different chapters do that. It notes the importance of engaging organizations of people with disabilities as full partners in the process. And in fact, some of the barriers and problems that were noted in the report was the lack of engaging sufficiently the people with disabilities and making plans, identifying topics for research. Sometimes research in rehabilitation, for example, takes on some very what was seemingly esoteric topics related to the science of rehabilitation, which of course we all know is important, but there are other issues that might be of more pressing interest to some groups of people with disabilities. So yes, the report does talk about engaging with and forming partnerships with people with disabilities through their organizations. I might note that organizations like Rehabilitation International and many others were involved, were consulted throughout the development of the report, and in fact on the editorial board and the advisory board were people with disabilities. I'm thinking specifically of Venus Alagan of the Philippines, who was on that advisory board. She's the head of Rehabilitation International. Kate Seelman from the United States, a person with disabilities, was on the editorial board. And so there was a lot of input to the report from people with disabilities, in addition to people who focused more on demographics and the science of it. The second, oh, now I'm hearing.
Yeah, Dr. Stone, the next question is about the impact on the fact that the United States has not ratified the UN Convention. How important is that?
Well, it's certainly important for us in the United States, but I think it's also important globally as well, because I think to the extent that the whole world is behind the convention, it gains more force. I think someone else mentioned that well, actually, we're about due to have another vote in the Senate on it very soon, I believe, if it's not blocked. I believe within the next few weeks, we're supposed to be having another vote in the Senate, and hopefully it'll be approved this time. As you know, it was signed by President Obama during the previous administration. The president did not sign it. And it seems to be related to this notion that avoiding being subject to international laws versus domestic laws, and being tried and held accountable. But the disability community in the United States and others, that their allies, have pointed out that really the convention, most of what's in the convention is already in the Americans with Disabilities Act that has been enforced for quite some time. I might mention that the USID, the United States International Council on Disabilities, is kind of leading the charge on lobbying members of the Senate, especially those who are not yet on board, to understand the convention and why it's important, and why it contains really no negatives for the United States.
Thank you very much. Any other questions or comments? Okay, well, again, Dr. Stone, thank you so much for your participation today. Thanks for learning Second Life to be able to come in world and present this speech. We appreciate it. And,
well, thank you for... Yes, thank you again for inviting me and welcoming me into this world. And I hope I won't be in another world in the future, that I'll be back in this world again with some regularity.
Good. We look forward. Oh, there's another question from iSky. Will there be another study and results from report at some time in the future on future progress? I think more generally, do we know, is there any follow-up planned to the World Report?
I'm not aware of any plan for another report like this, or another report to see what has been achieved. There is a plan within the World Health Organization. In fact, they're working now on developing guidelines, like what are some of the best practices that different countries and different stages of development might look at in formulating their own plans and building their own systems. The World Report is relatively generic. It contains a lot of useful information, but it was felt that maybe governments and agencies within government, as well as civil society, could use more guidance in actually how to do it. And so WHO is now planning to do a document such as that, to develop those needs.
Great, thank you. Since we have a couple of minutes, would you like to describe any in any more detail the work that CIRRIE does?
Okay, yeah, we have a website that contains a number of resources. One is what we call the International Database, or a database on international rehabilitation research. And this is an online database where we have gathered hopefully, if not all, the vast majority of research, published research conducted in other countries, that is to say, countries other than the United States. We've excluded the United States from our database because there is another database called Rehab Data that has a database of rehabilitation research conducted in the United States. So the two databases are complementary. So the CIRRIE database can be searched by year, by country, by topic, by language, and by a number of other parameters. And there is a crosswalk to the ICF, so you can even use ICF terms to do some searches. And it contains published research from 1990 to the present. Another resource is an online encyclopedia of rehabilitation, in which we tried to make that international. Our target was to have at least three-quarters of the authors of the articles in the encyclopedia to be people from other countries, as well as the reviewers of the articles. So we have roughly 300 articles on different topics related to disability and rehabilitation. Many of them are in Spanish and French. They're all in English, and we've translated many of them into Spanish and French. We've also addressed the area of cultural competence. This came up in the panel discussion preceding this session about the needs, special needs of recent immigrants in the area of disability and rehabilitation. And so we developed some educational resources for rehabilitation providers on the cultural perspectives of recent immigrant groups. So we developed a monograph series on the top 10 or 11 cultures of origin, or countries of origin of immigration to the United States. And we've had authors write about what their cultural perspectives about disability are, what might be some issues that might arise as they come into the rehabilitation or disability services in general. So, for example, what would you need to know about Korean culture or Jamaican culture or Mexican culture if you were a physical therapist working in a neighborhood that had a large number of recent immigrants from those from a country. And then we're also developed a series of curriculum guides for faculty in university programs that train physical therapists, occupational therapists, vocational rehabilitation counselors, speech therapists, and so on, such that students learn during their training, not just taking a workshop after they get into the workforce, but actually they start to interact with this issue as part of their regular technical training. The idea to develop some cultural competence in students coming out of these programs. The problem is that faculty members probably didn't have training on these things when they were students. So they really struggle a bit with including it in their courses. So by providing these curriculum guides, we provide a resource for instructors to enable them to more effectively deal with cultural competence in their courses. And the approach we have taken is not to have separate courses about this topic, but rather to integrate the topic of culture into the existing courses in the curriculum. Then we have other resources like a conference directory, a directory on the website that provides links to international conferences that are coming up. A country directory where for different countries we have links to different organizations that do rehabilitation research or related activities. And those are perhaps the main sections of the website, although there are others.
Excellent. Thank you for that overview. It is an amazing resource. A question came in from Sister saying the CIRRIE resource seems to focus on rehabilitation. Do you know if any equivalent globally oriented information and exchange resources exist in the area of education, early childhood through post-secondary?
I'm not going to be very helpful on that question. I'm sure there must be. There are different organizations that focus on inclusion, and I've heard of some of them, but I can't really pinpoint them specifically. It's quite possible that somebody else in your audience might have a handle on that.
Okay, well, thank you again. Let's go ahead and wrap up. There's approximately 20 minutes until our next session at the top of the hour from Christine Schneider about European language portfolios for specific purposes. Again, thank you very much, Dr. Stone. Wonderful presentation.
Thank you.